common pediatric conditions. Just tell me if I'm going too fast, huh? Okay. If we are all set, then we shall start. Okay, so this is an example of chest X-ray, no? PA and left lateral views, no? The most common ordered pediatric X-ray is a posterior-anterior film or PA film. Here we examine a normal chest X-ray of an adolescent with superimposed lookout lights to identify the specific parts of the chest radiograph. So can you see the arrow? I'm taking the arrow. Can you see it, guys?
Yes, yeah.
See the first one. Okay, so just follow my arrow. This is number 3. Okay, 8 vessels. You have your aortic arch over here. You have your pulmonary trunk over here. No? Just try to imagine the organ over the X-ray. You have your left main bronchus, the left atrium, the left ventricle, which is the border forming chamber of the heart. Okay, which is the left border forming chamber of the heart. Your right atrium, which is the right forming chamber of the heart. The RV or the right ventricle is the one anterior to the most atrium. You have your inferior vena cava, your diaphragm, you have your horizontal fissure. So imaginary, no? Sometimes you see it, sometimes you don't. So again, note that the horizontal fissure or the vertical fissure is only seen on the right, no? You have your oblique fissure, again, sometimes you see it, sometimes you don't. Okay? On the lateral film, you see the left main bronchus here. This is posterior of the left main bronchus. This is your inferior vena cava, left atrium, right ventricle, okay. Left ventricle, okay. So left ventricle is this one and this one. Right ventricle, the one that's forming the anterior border of the heart. Okay. Additional info lang, additional info. Checking for left ventricular heart hypertrophy, especially patients with congenital heart disease, no? We have a rule, no? This is your inferior vena cava, this is your posterior inferior vena cava. If the distance between the left ventricle, no? If the distance exceeds about 1.8 cm beyond the inferior vena cava mark, then you can be sure that it's left ventricular hypertrophy. So dapat ganyan. Dapat ganyan lang. It doesn't exceed beyond the LVC. So if it exceeds beyond, confident ka na left ventricular hypertrophy. Next, we study the contours of the heart, no? On your chest PA, you can see the lumps, no? Or contours or loculations in the heart. So let's examine it one by one. Okay, this one here is the ganglion aorta. This one is the aortic lump. You have your lump for the main pulmonary artery. You have your indentation for the left atrium. You have your border for the left ventricle. The right atrium is here. And in patients with congenital heart disease where there's left atrial enlargement, you should see a double density sign, which is not clear here, but it's supposed to be the same. Aside from the right atrium, you see another density here. This is called the double density sign, which is enlarged left atrium. So these are the contours that you may see, that you expect to see in the chest X-ray. Now, cardiothoracic ratio is normally up to 0.6, no, for patients 2 years and below. Is due to a more transverse position of the heart. It's up to 0.5 for patients 2 years and above. So adult patients also 0.5 degrees of that. So how do you get the cardiothoracic ratio? You measure the width of the base of the heart and divide it by the width of the lower thorax, the large diameter of the thorax. That is how you arrive at the cardiothoracic ratio. Okay. So for preliminary investigation or evaluation of the chest radiograph, we assess these factors. Primarily, we check for inspiration, rotation, and penetration. The degree of inspiration measures the degree of the lung volume. The position of the patient, we measure for the extent of rotation and posture of the patient. And we check for penetration, we check for adequacy of exposure. I personally added that we should also check how the film was obtained, whether it's PA or AP or upright or supine. So you should assess for these technical factors. Okay. Okay. First, to check for lung volume, we examine these two X-rays. These two images. The radiographic examination of the chest begins with a frontal and lateral radiograph taken after the inspiration. Now, if the child is taking shallow breaths, the heart may appear enlarged. No? The vessels may coalesce to give a false impression of an opacity or infiltrate, or even congestion, especially in the basis and in the hinder meter. Also, the chest may appear generally hazy, possibly due to influx of blood or positive aerated lung. Now, here we see the chest radiograph, where the heart appears to concentrate on the image on top. No? Here we see chest radiograph, where the heart appears enlarged. No? So it looks enlarged naman talaga. Now, the vascular markings along the unit.
Dok, nawala po yung...
Ay. Saan banda ako nawala? Which part?
Two sentences lang, Dok.
2 sentences lang. Okay, let me start again over. So to check for lung volume, okay, the radiographic examination of the chest begins with frontal and lateral radiograph taken after the inspiration. The vessels may coalesce to give a false impression of an opacity or infiltrate. No? The chest may appear generally hazy, possibly due to influx of blood or positive aerated lung. To examine these two images, no, let's concentrate on the image on top. We see that the heart is generally enlarged, no? Heart appears enlarged. The vascular markings along the inner lung zones are accentuated, and there is haziness in both lungs. Okay, so you'll be thinking that may cardiomegaly siya, you'll be thinking also ng congestion, and possibly may basal pneumonia also. However, the second image below is the same patient taken on the same day, but with better inspiration. Okay, repeat the same day with better inspiration shows that the heart is now normally sized, no? And the vascular markings is clearly no less congested as the previous X-ray, no? Ito, same day lang to, same time, same time. However, the haziness on the right arrow, the haziness on the left lung base is constant, for which conservation is now considered, is now confidently considered. No? So, this is just an image showing the importance of inspiration in patient for the chest radiograph. Okay. Now, in this patient, no, you can see that the diaphragms are flattened completely, even though from the usual dome. Now, in this patient, no, the diaphragms are flattened completely with the loss of the usual dome. In small children, flattening of the diaphragms are best demonstrated in the lateral view. Note also that the vertebral bodies get blacker now as we go from superior to inferior. Lateral examination confirms the normal elevation of the lungs. So if you see haziness in this area, if you see that this area is more bright or more opaque than this area, then consider something. Consider the angiopathic or infiltrate and the posterior aspect of the lung. Okay. So next, we go to normal spiritual chest images. No? Normal spiritual chest imaging. You should expect that the heart, less than 1/3 of the heart is projected below the diaphragm. Okay? Dapat less than 1/3. The diaphragm should not exceed more than 1/3 of the heart. So less than 1/3 of the heart is projected below the diaphragm. The diaphragm should appear rounded as opposed to flattened in hyperelevation, as I demonstrated earlier. So this is best seen in the lateral view, the flattening, especially in younger children. No? The flattening in the diaphragm is best seen on lateral view. The lung field should appear black or air-filled. No? Now we should ensure that 8 visible posterior ribs are seen in children ages 0 to 3 years old, at least 9 posterior ribs in children ages 3 to 7 years old, and at least 10 posterior ribs are seen in children ages 7 years old and above. Again, let me just point out the ribs that are, for the interns and the tertiary, the ribs that are more horizontally oriented, no, are the posterior ribs. This one, ito yung more posterior ribs. While the ribs that are more vertically or obliquely oriented are your anterior ribs. No? Anterior ribs, you want this one. Okay? So this is clear. Next, we check for rotation. if this, so this is an example, no? It's an example of a properly positioned, non-rotated film as evidenced by the anterior ribs which are equidistant to each other. Symmetrical placement ng mga ribs natin. The clavicles are symmetrically positioned also, meaning that the spinous process of the vertebra, the spinous process, should be equidistant from the medial ends of the clavicles. There is no rotation. And also there should be no difference in aeration between the two sides. Kung dapat one side is not darker than one side. Also, one additional note, you should check for air fluid level in the stomach to check if this is actually erect film or upright film. Okay? So this air fluid level here, you know that this is an erect film. Okay. This is an example of rotated chest, no? There is a symmetry of the clavicles, as you can see. Okay, there is difference in ratio, no? This one is darker than this side, no? And the heart is abnormally projected over one side, not particular. The heart is abnormally projected in one side. And there is asymmetric rib placement. So, iba ang forma ng rib. So, you know that this is a rotated film. Okay? And do not diagnose easily pneumonia here or hypertension. Okay, next we check for the adequacy of exposure. If there is good penetration of X-ray beams, no, we should be able to appreciate the thoracic spine. No? Through the heart, here, this image, we should be able to appreciate the thoracic spine through the heart. Okay. Behind the heart, you can see the medial spine and the pedicles. No? These are the pedicles. No? Through the heart, and also see the pulmonary vessels in the cerebellum. You should also see the pulmonary vessels here and the thoracic spine. Then the exposure is correct. Now, if you see only the spine, but not the pulmonary vessels here, meaning dark lang siya, you only see the spine. And the vessel, then the film is dark and is over-penetrated. So this is important if you want to check for factors, but not during, but not for chest X-ray, normal chest X-ray. Now, if the film is under-penetrated naman, this left hemic diaphragm is not really visible. This is generally easy, and this part is actually obscured. No? Baka maisip niyo, you might mistake it over a pneumonia. So just check if it is adequate or normal penetration of this study. Okay? Are we clear with this one? Everyone? Okay. Number 13. Okay. This is the factor that I added on how the film is obtained. You should also check first if the image was taken on PA or posteriorly or anteroposteriorly or PT. Because greater magnification occurs when the structures such as the heart are farther from the film, di ba? That this one, no? The heart is more or less nasa anterior part of the thorax, no? Project a beam this way, AP, no? The heart becomes larger, no? As compared to if during X-ray done with PA view, the heart becomes more or less a normal size, no? So when the X-ray beam passes to the patient back to front, the heart is closer to the film and less magnified. So conversely, if the X-ray beam enters from the front, no? From the front, the heart becomes magnified and may give the impression of argumentally. Okay, so what are the disadvantages of an AP projection? No? You may ask, ano bang kaiba na? What is the difference of AP or PA? So AP projection are generally of lower quality than PA images. No? So the scapula are not retracted. You may see that the scapula here should be retracted to the sides in PA view. If you were asked to, if anyone has had an X-ray before, you were asked to actually embrace or hug the cassette, no? that would displace the scapula to the sides. No? The scapula are not retracted laterally and they remain projected over inches lang. So medyo nakaka-obstruct pa siya. And the heart size is saturated. At this AP image, you see the scapula over here, and the heart size is medyo magnified, no? And the vessels are a bit accentuated. As compared to this one, from the same patient, the scapula are retracted to the sides, the heart size is a little bit of normal, no? And the vascular margins are not congested, no? Okay. So are we done with this? Are we okay with this? Okay, supinal pride. Supinal, when the child is sitting or standing, no? Gravity plays a significant role, and the upper lobe vessels are less distended than the lower lobe vessels. However, in patients who are in the early stages of congestion, septalization occurs. Septalization means that the upper lobe vessels are actually equal in caliber to the lower lobe vessels, even if the patient is upright, no? Equal pa rin siya. When the patient is supine kasi, the vascular markings tend and the upper and lower lobes appear equal since gravity has no effect. So there's the settling of the vascular of the blood flow. More or less the caliber of the upper lobe and the lower lobe vessels are equal, no? When the patient is supine. In babies, supine AP projection is usually requested. However, in toddlers who are able to stand up, we usually request the direct anteroposterior view, no? So the general rule is if the patient is able to stand, mas maganda if the AP request for an AP view standing or PA view standing. Okay? Okay, so as I mentioned, PA view is preferable to the AP film view, as the latter may result in a magnified hard shadow, as I mentioned, no? AP films, no? AP films are reserved for those patients who are too unstable, for those patients who are unable to stand, such as babies, no? Or for those patients who are unstable to move and a portable machine is used. The portable machine kasi you can only shoot an AP view, so that's that. Okay. Okay, first case. So this is what I added from the last lecture, no? I will be throughout this lecture I will be giving cases which we can go through together, no? Now for this first case, we have a 6-month-old boy who comes in with cough and fast breathing, no? A chest X-ray ordered for this patient. Now first, what you do, no, diba? Based on the factors of a good X-ray, we are certain that this film is that. Okay, first thing first, we are certain that this film is that of your patient. Check for the name, and check for the view that's requested kung tama pa ba, and check for the correct X-ray view that has been obtained. We should also note that the penetration and inspiration are adequate, as the vertebral bodies, as you can see in this image, no, are visible through the heart, and also approximately 8 to 9 posterior ribs are seen, no? So tama rin ang kanyang inspiration. We also conclude that the rotation is normal because the clavicle are more or less equidistant to each other, no? And the rib placement are more or less equal, no? There's also no difference in the lucency of the lungs, no? So we have already asserted that it's good penetrated, good X-ray with good inspiration, and no rotation, no? So yun lang naman, systematic review lang. However, you should, after you ascertain, no, that this image is of good quality naman, of good was taken in a very in a satisfactory manner, no, you can begin interpreting the film, no, using the top to bottom approach. That is how I read it, no, from top to bottom, para wala akong mag-miss, no. So you start at the top and note that there seems to be an increased opacity, no. If you can see this, guys, no, there seems to be an increased opacity at the right lobe of the lung, no? At the right upper lung. What do you think this represents? 2 seconds lang. So, okay, this area of increased opacity actually represents the normal thymus, no, in a pediatric patient. The thymus in a pediatric patient is highly variable in size and shape. It can shrink in size actually following illness or increase in size following chemotherapy. Okay. So, the thymus gives rise to prominent anterior mediastinal shadow, no? It can be recognized by its characteristic sail shape, no, with wavy margins. So sail shape with wavy margins. It becomes less evident between the ages 2 and 8, after which it can be visible anymore on frontal chest X-ray. Now sometimes the normal thymus can appear very large and may need to be differentiated from a mediastinal mass or consolidation. Remember, however, that the thymus does not displace the trachea, no, to another side, and is bounded by the minor fissure inferior. So this is your supposed area of the minor fissure, no. The thymus does not go beyond this. Now, if the opacity over here in an infant actually pushes the trachea, displaces the trachea or goes beyond the minor fissure, then think of another entity other than a thymus. This is your sail ship. Sail ship, this is your inferior margin. The inferior margin of the sail is actually your minor fissure. Okay. Okay, so we should now do a systematic review of the chest X-ray. First, we start with the trachea and the hilar regions. In infants, the trachea may buckle anteriorly and to the right on expiration, but below the thoracic inlet, the intrathoracic trachea should appear straight on lateral X-ray view, even on inspiration. So on lateral view, dapat di siya gagalaw, even on inspiration. So anterior or posterior displacement of the trachea, you should suspect for a mediastinal macular. Also check for if there is narrowing of the trachea. Subglottic narrowing or narrowing of the trachea at the area of the neck, is most commonly seen in acute laryngotracheal bronchitis or flu. Differential diagnosis for this subglottic narrowing include extrinsic compression by a vascular ring, or impacted esophageal foreign body mass, or congenital tracheal stenosis. Conversely, widening of the trachea is seen during prolonged intubation, cystic fibrosis, or congenital tracheomegaly, or Muir-Kuhn syndrome of NPS. Okay, case number 2. Our second case involves a 12-year-old patient, that presents with weight loss over the last 6 months. Again, we do our systematic reading or investigation of the chest image. The chest film is slightly underexposed. Okay, underexposed because the vertebral bodies are not easily seen. Hindi masyadong makakita ang vertebral bodies through the heart. Okay, but you can count 9 to 10 ribs, which are visible, which would denote that this is of good inspiration naman. The clavicles are equidistant, which would denote that this is a non-rotated film. So talagang poorly exposed ng image. Okay? So are there any abnormalities that you can see? Ayan, may arrow na. Okay, first we remember that this patient is 12 years old. So we do not expect to see the thymus on the chest film, and indeed it's not visible naman talaga. On the film, it seems as though there is a round opacity on the left hilar region. There appears to be mild leftward deviation of trachea as pointed by the arrow. Okay, hilar shadows. This may be due to hilar lymphadenopathy because of viral pneumonia or chronic infection. But when markedly enlarged, you consider tumor infiltration, TB, or sarcoidosis. As you can see in this image, klaro naman talaga. It's evident that there is somewhat a nodular fullness in this area. It's evident on the lateral view. This is not normally seen. These nodular opacities that actually surround the trachea and the hilar and the paratracheal region. So if in cases like this, you consider hilar lymphadenopathy in viral infection, but if it becomes markedly enlarged, you consider tumor or head. Okay, first we need to ascertain that the mass is indeed intramediastinal. If the mass is indeed intramediastinal, if you can see air bronchograms through the mass, this is not an intramediastinal mass. So kasi pag intramediastinal mass, you don't see vascular the lung markings through it. Okay, intramediastinal masses do not contain air bronchograms. Now, for the mediastinum, it's divided into 3, mostly 3. It's divided into the anterior, the middle, and posterior sections. The middle section is comprised of the great vessels, the trachea and the esophagus. Certain clues are important to remember in order to localize the mediastinal mass. One of these 3 sections. Okay, that is check na muna. So this is your anterior. Let me just show you. This is your exposed location of your anterior mediastinum. This is your middle mediastinum, the one colored in yellow, and the green part is your posterior mediastinum. Structures that are seen in your anterior mediastinum include the thymus, lymph nodes, the internal thoracic vessels, and thyroid tissue. Structures that are seen in the medial mediastinum include the heart, the aortas, the vena cavas, the brachiocephalic vessels, the pulmonary vessels, the trachea, the main bronchi, and the different nerves. Okay? While posterior mediastinum will see the esophagus, the azygos and hemazygos, and the descending aorta. Okay. Certain clues are important to remember, no, in order to localize the mediastinal mass to one of the three sections. If you see posterior deviation of the trachea, no, or obliterated costophilic angles, effacement of the ascending aorta, and visualization of the higher vessels to the mass, as in our patient, no, this is indicative of the anterior mediastinal mass. No? With the anterior mediastinum, a mnemonic called the terrible piece is considered. Terrible piece are considered. No? We have the germ cell tumor or teratoma. We have the thyroid lesion. Okay. Thymus tumors. Okay. Thyroid tumors, thoracic aorta, or terrible lymphoma. Okay, let me repeat. For the 5 T's, the terrible piece in the anterior mediastinum, no? We have the thymus tumors, we have the teratoma or germ cell tumor, we have the thyroid tumors, we have the thoracic aorta, lesions in the thoracic aorta, or terrible lymphoma. Okay, these are the 5 T's that you see in the anterior mediastinum. Now, for the middle mediastinum, you usually see here aneurysm, or bronchogenic cyst, or diaphragmatic hernia, or lymphadenopathy. So, yung patient kanina pala, the one that we showed earlier kanina, the patient actually has lymphoma. This is a anterior mediastinal mass. However, it has gone big enough to actually push your trachea to the side. Because pushing the trachea to the side is actually is actually seen in middle mediastinal tumors or middle mediastinal masses. No? Lateral deviation of the trachea and widening of the paravertebral line, okay, are indicative of a middle mediastinal mass. Okay? Organs seen here, as I mentioned, and disease entities seen here, as I mentioned, include aneurysm, bronchogenesis, hernia, or lymphadenopathy. Okay. Lastly, if you see splaying or destruction of the posterior ribs, an extension of the mass above the superior clavicle, and also calcification, this is indicative of a posterior mediastinal mass. Examples include aneurysm again, especially the descending aorta, and esophageal disease. Lymphoma also can be seen in the posterior mediastinum, meningocele or neurogenic masses because it's close to the vertebral body. I hope you're all clear, no? With the mediastinum. The terrible piece, middle, we see lateral deviation of the trachea, and posterior, it usually extends to the thoracic vertebra. Okay, then this is just actually just a summary of the practice that we see in mediastinal masses. Anterior mediastinal masses is suspected when the trachea is deviated posteriorly. Okay, terrible piece. When the aortic knuckle is obscured, you consider anterior or middle mediastinal mass. If there is lateral deviation or separation of the trachea from the esophagus, you also consider a middle mediastinal mass. You check the position of the entity if it's deviated from the trachea. If there is a posterior mediastinal mass, you may show areas of calcification or splaying or destruction of the ribs. No? Okay, this is the same case as kanina. This is a functional disease patient, 12-year-old female with cough and shortness of breath. Okay, you can actually see the lobular mediastinal mass here. Okay, that extends to the left. This is the presence of the mass involving the anterior and middle mediastinum. So there's actually lateral displacement of the trachea, and if you can see in the posterior lateral view of this, you can also note there is posterior displacement of the trachea also as well. Okay, we have gone through the different entities, different factors that we consider when interpretation of chest X-ray. We now go to lung and pleural patterns of the disease. So case 3 again. Try to examine the image first. Okay. This is a 15-year-old female a male with difficulty of breathing. No? Looking at the X-ray again, you note that the film may be a little bit under-penetrated because as the vertebral bodies are invisible, as you can see. At the same time, the lung fields also look darker on each side than normal. So, however, if you move along, you find that the inspiration and rotation are normal. So, because there are at least 10 ribs, and there is the ribs and the clavicle are equidistant to each other. No? However, the lung fields look taller than normal. You do not also see the thymus because it's already 15-year-olds. No? The heart seems to be regular in size and shape. Okay. And the normal lung should also include thin white lung markings that are extend almost to the periphery of the lung fields. However, this diffuse bithoracic increased translucency, which may be present in a well patient, who has taken a big breath. And also present in patients with increased aeration. So this is increased lucency of the film is seen in patients who have taken a big breath, or in films with overexposure of the film. But however, it may also be seen in patients with asthma, bronchiolitis, cystic fibrosis, or upper airway obstruction. This is actually a case of cystic fibrosis. Another feature of cystic fibrosis, you may also see that there is increase in the bronchovascular markings in the hilar regions. This is seen in cystic fibrosis. Okay, so for the first part in the lung pleural patterns of the disease, we examine the factors that increase the translucency of the chest. So there's generalized increased lucency. We also see flattened diaphragms, which may be seen in a healthy child with large inspiratory effort. It can be also seen in patients with air trapping in asthma, bronchiolitis, cystic fibrosis, or bronchial foreign body. Now, in patients with unequal translucency, we always exclude patient malrotation. Okay. So for this side, for the abnormal side, is the one with decreased vascularity. So if there is least change on expiration, the disparity between two sides will become more pronounced in expiratory phase. Now, this is a case of a patient who actually ingested a peanut, that's lodged in the right main bronchus. So this is an expiratory film. In expiratory film, the unaffected side should actually return to its normal vascularity, less darker siya. However, the affected side retains its darkness. So if you are suspecting for ingestion or inspiration of a foreign body, you suggest for an X-ray in expiratory view. Expiratory view. You note in your request. X-ray in expiratory. Okay. This is another example of a patient with congenital overinflation, which is also previously known as emphysema. It's evident at the right upper lobe. There is the resultant collapse of the right middle lobe, as well as the right lower lobe, and to some extent the left lung. Note the reduced vascularity of emphysematous right upper lobe. Okay, another case naman of a patient with collapse or hypoplasia of the left lung. There is hyperlucency that is marked on the right lung because it's compensating for the volume loss on the right lung, on the left lung, sorry. The right lung shows compensatory emphysema due to collapse of the left upper lobe. Note the prominent vascularity in the right, indicating that this is a normal size. Okay, case number 5. Okay, try to give it 5 seconds to try to examine the images. Water. It's a 3-day-old child, with worsening respiratory distress. On the first image, you see that there is areal hyperlucency in the right pneumothorax, Okay. The patient actually presents with worsening respiratory distress, While on continuous positive airway pressure or CPAP. A chest film is ordered. The PA upright film is well penetrated naman, You can see the spine through the heart, And the vertebra and 9 to 10 posterior ribs are actually present, so this is good inspiration. The clavicles are equidistant from the spinous facet, noting that there is normal rotation. The thymus is not visible in this film, and no obvious masses are visible. So this is actually okay. The heart's width is less than 60% of the mediastinum, no? Now let's look at the lucency of the lungs. There seems to be an area of hyperlucency, no? If you agree with me, there is an area of hyperlucency in the right upper lung, and also seen in the left lung. There also seems to be a tube, no? As indicated by the arrow. It's inserted into the right upper lung. Okay. See the old neonate with pneumothorax with chest tube. So this is a case of pneumothorax, no? See the old patient has a pneumothorax. And pneumothorax can actually occur as a result of trauma, injury to the chest, or as a complication of a long-standing lung condition, or as a spontaneous idiopathic entity. Now, in adolescents are tall and thin, there is a higher risk of developing spontaneous pneumothorax. No? So, pneumothorax in neonates are often idiopathic in nature, but are also associated with complications of ventilator and therapy. As with our patient, a pneumothorax is visualized as an area of radiolucency between the chest wall and the lung. In other words, this area appears darker with no apparent lung markings within. No? Our patient also has a chest tube that has been inserted in order to help drain the air. On an upright film, such as in our case, the air accumulates in the lung apices. No? In addition to neonatal pneumothorax, you may also see the presence of a hyperlucent or dark postophrenic angle. This is known as deep sulcus sign. Sometimes, if the pneumothorax is not that large, no, the only abnormality that you see in the frontal view is a deep sulcus, no, or a lucency outlining the sulcus. This is what's called a deep sulcus sign, and actually represents a pneumothorax. In patients with air leak, usually you see the visible lung edge, no, which is the visceral pleura, with increased lucency of the adjacent thorax, no? And you should also note that there is absence of lung markings within this lucency. So in this image, this is your area that is filled with air. This is your area of pneumothorax, and this is actually your collapsed lung, no? Okay. Sometimes there is concurrent fluid build-up within the thorax, no? In a patient with pneumothorax. Okay, this is your increased lucency seen in pneumothorax. And actually, there's air fluid leveling, very seen in fusions. This is actually a case of pneumohydrothorax. Okay, see absent lung markings on this side, and air fluid leveling denoting pneumohydrothorax on the right. Okay. So if pneumothorax is suspected, no, a lateral decubitus film should be obtained, with the site in question being the site that is facing upwards. No? So if you're considering a small pneumothorax here, we request a repeat X-ray, lateral decubitus, with the side that is in question upwards. No? So you see the lucency here. It is more clear here, no? Mas kita siya on lateral decubitus here. Okay? This is an example of massive pneumothorax, wherein the lung is relegated, the atelectatic lung is relegated to this mode structure. Okay? Okay, not all opacities that look like this are considered as pneumothorax again. Okay? This, again, you should check naman if the vascular markings actually go past this line. You know? If you consider this the visceral pleural line, how come there are still vascular markings here? So the most common answer to that is it could be a skin fold. Skin fold actually mimics pneumothorax. So what you do is you check whether the vascular markings actually extend beyond the visceral pleural line. Okay, are we clear with this? No. Next, we go to pneumomediastinum. Now, if the air seeps through the mediastinum, it actually outlines the lobes of the thymus as the air tracks along the soft tissues of the neck. Okay, lateral view may also be useful to confirm the mediastinal air in the retrosternal space. Now, if you can notice, this is a patient with pneumomediastinum, no? This is a patient who is intubated. Tapos you can see naman the outline of the heart. This is actually what we call the continuous diaphragm sign. Kasi in a normal patient, normal chest X-ray,
Bronchoscopy
the
daw.
heart rests on the middle part of the of the diaphragm. No? You don't actually see
Endoscopy daw.
the diaphragm on this side, no? You only see this one diaphragm here and the diaphragm here. So when the mediastinum is filled with air, no, it actually lifts up the heart, no? Naaangat siya, actually showing the continuity of the diaphragm.
This kind of
Okay.
argument.
So this is a continuous diaphragm sign that you should suspect in patients with mediastinum. Okay. So contour of the heart, continuous diaphragm sign, and the outlining of their thymus.
Ngayon, abdominal X-ray daw.
Okay, spinaker sign. Actually, showed you this image a while ago. No? Okay, this is just to show you that in lateral view, you can confirm the presence of pneumomediastinum that outlines the heart. No? And then spinaker sign. Okay, the lobes of the thymus is actually elevated because of the air in the mediastinum. It actually resembles a sail, like this, a spinaker sail. It's seen in pneumomediastinum. Okay, so if you see air naman, no, you can see sometimes you see only air because that's the most striking thing that you see, air in the neck that seeps through the soft tissues in the neck. Consider pneumomediastinum agad. Okay? You can see air here, and actually the heart, no, is well delineated, it's outlined by air. And you can somewhat see pneumomediastinum or continuous diaphragm sign. Okay? Lateral view is more evident. Okay, the outline from the heart is more clearly delineated by the air within the mediastinum. So if you see air on the neck, check for pneumomediastinum. Okay. After the factors that increase lung lucency, we now go to the factors that increase pulmonary opacity, pulmonary haziness. Examples include lung infiltrates, lung collapse, atelectasis, or hypoplasia, or agenesis, or pleural fluid, or chest wall lesions, or tumor, or masses. No? Next case, we have an 8-year-old boy presenting with cough, fever, and lethargy. So 53 seconds to examine the image first. Okay. Okay, first start off by checking. You start off by checking that the film is for the right patient. Again, this is the first thing that you do, no? Then ascertain that the film is of adequate quality by checking the penetration, the inspiration, and the rotation. All of these three components are fine with this film, no? You can see the thoracic spine, the ribs are equidistant, the sternum are equidistant, no? The lungs are well aerated. All of these three components are fine with the film. Now you start analyzing the film itself, no? From top to down. Okay? The pulmonary vessels are clearly demarcated and tapered gradually, no? Okay naman ang pulmonary ang vessels, no? It's actually tapered gradually, no? But you notice an area of opacity here, no? On the right upper lung. Okay. Let's take a look. This lung looks like it's rounded, no? Well circumscribed. There is no central cavity, but you can see some branching lucencies, no, within, no, through the mass. You can see the mass. What are your working diagnosis? What do you consider with this? Could this be a mass or another entity? Okay, this is actually, no. Okay, tama. You can actually call this a pulmonary nodule. Okay. Okay. This is actually a pulmonary nodule, no? The pulmonary nodules are discrete areas of opacity within the lung. Of these, the round pneumonia is the most common type of solitary lesion in the pediatric population, no? But you will not be wrong if you consider this a mass, no? Actually, this patient indeed has a round pneumonia. But your differential could include a mass, but you will not be wrong. If you consider a mass, you can include a bronchogenic cyst, a pleural fibroma, or a fungal infection. However, the presence of the lucencies that I mentioned earlier, or are called the air bronchograms, would tend to point towards the diagnosis of a bacterial pneumonia. No? Again, an air bronchogram is when a normally dark air-filled bronchi is made visible by the opacification of the surrounding alveoli. Round pneumonia is the most commonly present in those under 8 and is located in the lower lobe. Pneumococcal infection is the culprit in the majority of the round pneumonia cases. Now, the film on the right is the follow-up study taken after 10 days after antibiotic therapy, which shows resolution of the mass. So not all masses that look like this are actually neoformative masses or mass lesions. It could also be a pneumonia as evidenced by this image. 10 days after antibiotic therapy, nawala na yung mass. Okay? Here's the shadow. Ears of decreased opacity with air bronchograms are actually called pneumonia or consolidation. These are typically associated with infection, which could be segmental or lobar. In patients with diffuse haziness on both sides, which are symmetrically placed, you should also consider pulmonary edema. Now, this is a study with air space shadowing with prominent air bronchograms within. Air bronchograms are marked by the arrowheads, as you can see. These are the bronchograms that are seen through the opacity. Okay? An example of a lobar pneumonia demonstrating again air bronchograms. Okay, this is just a representative image of what happens when there is an air bronchogram. These are your air distal ascinon or your cells, These are your bronchograms. These are your bronchograms. Bronchograms are branching lucencies within the opacified lung, Air bronchogram would denote air vacancies such as pneumonia, pulmonary edema, or pulmonary embolism, which fills the bronchi and actually makes this area more prominent. Now, this thickening may also happen of the interstitium. Following thickening of the pulmonary interstitium or alveolar walls, or inflammation or fibrosis, or infiltration with or increased interstitial fluid. So this is what we call interstitial thickening or interstitial infiltration. This is a patient with bilateral interstitial pneumonia due to mycoplasma pneumonia, and this is a patient with pulmonary edema, interstitial shadowing with prominent linear patterns, and the fluid in the horizontal fissure as seen in this arrow. So these are examples of interstitial infiltration or interstitial thickening, which could be seen in pneumonia or a cardiogenic disease. Other interstitial patterns that can occur commonly associated with chronic disease include reticulonodular pattern, a nodular pattern, a miliary pattern, or a honeycomb appearance pattern, which can be seen in end-stage diseases such as in our setting. It's more common in patients with tuberculosis. If you see too many lines, it's actually a reticular or opacification. If you see too many dots, it's a nodular pattern, And if you see a mix of the two, reticulonodular pattern, meaning too many lines and dots, this is how it looks like. So these are just common end-stage chronic diseases of interstitial thickening, interstitial pattern. Next, we go to atelectasis. Atelectasis is actually decrease in lung volume or collapse of part of all of a lung, appearing in areas of increased opacity. Actually, in atelectasis, the midline structures should be shifted toward the side of the collapse. Okay, midline structures are shifted toward the side of the collapse, and there should be also compensatory hyperradiation of the opposite lung. Now, atelectasis can be divided into microatelectasis, then seen in RDS or general atelectasis, which is diffuse AC opacity with whiteout, or seen in severe RDS, airway obstruction, or when the ATP is not in the trachea. And finally, we have lobar atelectasis, which involves usually one lobe. The most common site of lobar atelectasis is the right upper lobe, with resultant elevation of your minor fissure. Okay. Now you see direct signs of atelectasis, which is the deviation of the fissure. On one side, the lung margins become crowded, and you actually see the opacification. These are direct signs of atelectasis. For indirect signs of atelectasis, you see the shift of mediastinal structures. This is an indirect sign. You see elevation of the diaphragm, which is an indirect sign. Narrowing of the rib spaces, and compensatory hyperinflation of the unaffected side. This is just a representation of what happens to atelectasis. The air cells with ascinon actually collapses. There's loss of volume of the air cells. Never mind this. Okay, tumor masses. Mediastinum is shifted towards the contralateral side if you have a mass, check for calcification or bone destruction to actually further delineate, further localize where the mass is located. If this mass is well circumscribed, it actually pushes the trachea to the other side. Again, you consider a mass. You can also consider pneumonia. It's part of the differential style. Okay, mass may present as a large opaque hematothorax, which is difficult to differentiate from a large pleural effusion. That's why we also request for ultrasound when we are dealing with this kind of X-ray, in this opacity. Primary consideration would be fluid pa rin, but masses can also look like this, as evidenced by this ultrasound finding, where this is done actually prenatally. There's blood supply to this opacity. Okay. It's actually a mass lesion, not a fluid within the thorax. Next, we have a pulmonary nodule. As I mentioned earlier, the most common is solitary pulmonary hepatitis, is a round pneumonia, often associated with pneumococcal infection. Air broken crumbs should be seen, However, in acute phases, early phases of the round pneumonia, air bronchocrum may not be visible. So that's that. It could be possibly misinterpreted as a tumor. Okay, multifocal nodules may be due to multiple metastases, multifocal infection, granulomas, or papillomatosis. So if you see multiple nodularities, you consider metastasis. That's the first thing that you consider. Ring shadow, ring shadow. It's thin-walled, it's hair-filled, it's cystic, it may be solitary or multiple. Okay, pneumatocysts are the most frequent masses that present like this in children, mostly affecting the middle and lower lobes, It's usually due to staphylococcal or streptococcal infection. Pneumatocyst is infected, actually presents with air fluid leveling within. Okay. Another example of ring-like lesion or ring-like mass lesion are congenital lesions, which appear as solitary thin-walled lesions, which include bronchogenic cyst or extralobar sequestration. Now, if you see complex masses posing as multiple ring-like masses, you could include actually congenital diaphragmatic hernia or CTAM or cystic adenomatoid malformation of the lung. This is an example. You can see multiple cystic masses in the thorax, okay, in this study as well. And one clue here is the absence of the bowel loops in your abdomen. So this we can confidently say that this is a case of diaphragmatic hernia. CCAM can also present as this one, So pwede siyang diaphragmatic hernia, pwede siyang CCAM, congenital adenomatoid malformation. Okay, let's go to the sixth case. Examine lang muna the image, This is a case of a 3-year-old with chest pain and tachypnea. The patient actually has previously had a history of cough and fever for the last 10 days. So let's take a look at the X-ray. The vertebrae again, let's start again. The vertebrae are present, The vertebrae are present through the heart, 9 to 10 ribs are visible, and the clavicles are more or less equidistant to each other. The thymus is not visualized. It is hard to comment on the heart side because it's obscured. Okay. So upon cross-examination of film, the most remarkable finding, the first thing most remarkable finding is unilateral opacity, present diffusely on the left lung. More so, the right lung field seems to be decreased, and the heart seems to be shifted, towards the right side. So what is your clinical diagnosis? So, our patient here has a pleural effusion as a result of a complication of a previous pneumonia. So as seen on our patient's film, pneumothorax on supine film is diffusely hazy, as increased opacity may be indicative of a pleural effusion. Now, large pleural effusions may shift the mediastinum to the contralateral side. Now, if the pleural effusion is suspected, an ultrasound of the chest should be carried out to determine whether the fluid is actually confined to one area or loculated or freely moving. Now, if it's freely moving, the latter is freely moving. This is amenable to percutaneous drainage. Ultrasound will also help to determine the quantity and quality of diffusion. Diffusions present in the pleural cavity may be an empyema, collections of pus, a pneumothorax resulting from chest trauma, unexuded diffusion from a diseased nervous structure, which includes subdichromatic abscesses, pericarditis, or pancreatitis. Now, the only realistic way to differentiate these entities is through torasynthesis and pleural fluid anatomy. Okay? So if we see opacity with meniscus forming in homogeneous opacity in the left lung, we consider for diffusion. We should also dapat wala siyang air bronchogram. There's always sometimes, most times there's contralateral intestinal slip. And in patients with very minimal pleural fluid diffusion, the only thing that we see is actually blunting, of the suicide, or opacity here that obscures the suicide. Sometimes yun lang nakikita mong abnormality in pleural diffusion, especially if it's very minimal. Okay, so again, if you have pleural diffusion, if you want to confirm if it's really pleural diffusion, you ask the patient, you request for a decubitated view with the area of question below, so right side down. If the question is with the area of question is on the right, you request a right lateral decubitated view, and you can also see layering of fluid in this area. Okay, conversely, left side down, you see layering of fluid in this area. Okay, that's what you request if you really want to find out if diffusion is really actually present. Layering density in the dependent portion of the pneumothorax. Okay. Now, as I mentioned earlier, especially in supine patients, what you see are just veil-like haziness. It's also a feature of pleural diffusion and a lateral band detention, especially in patients who are lying supine. Okay. When you request for lateral decubitated view, especially in this patient, you're examining the right pneumothorax. Don't forget to look also at the left pneumothorax. If there's fluid here, you can actually see it here. Yeah, this side. So huwag na mag-focus on this side. Also check this side. If you're doing a lateral decubitated view, to check for pleural diffusion. Case 7. This is a 13-year-old with shortness of breath. Actually, this is medyo out of line siya sa flow ng I just had to add this. Actually, a case of asthma. 13-year-old with shortness of breath and increased work of breathing. Take a look at the X-ray. Again, the vertebrae are present on the heart. The clavicles are equidistant from the spine. However, the inspiration seems to be a bit abnormal as to 11 to 12 ribs are counted. Okay. There are no masses apparent. The mediastinum on the heart is normal shape. Okay. So there are no sets of pleural effusion or pulmonary nodules. What the striking feature here is the flattening of the hemidiaphragm. Tama tayo. And in this image as well, you can see that the bronchovascular markings are coarser as well. So, I mentioned already this in the case of asthma. A flattened diaphragm is most often due to an overinflated lung, as seen with our patient. Our patient actually studied chronic asthma that has resulted in hyperinflation of the lungs and flattening of the diaphragm. Another feature that may be present is that a peribronchial coughing or thickening of the bronchial walls, as seen in this patient. Thickening of the bronchial walls or peribronchial coughing. You may be able to appreciate in the patient's film that the bronchial walls are more apparent than on a normal film. So mas halata, mas klaro ang bronchial walls on this patient with chronic asthma. So findings in asthma usually, the more striking ones are hyperinflation, bronchial wall thickening, or peribronchial coughing or X-ray, which is a non-specific finding but may be seen in 48% of patients with asthma. But the most common chest radiographic finding in uncomplicated asthma is always a normal chest X-ray, which is seen in 75% of patients with asthma. So these figures are actually got from Radiopedia. 75% usually normal. So in patients with peribronchial coughing, 48% we usually have asthma. Okay. So for summary, we have checked for inspiration. You count the number of ribs. Rotation, if you check if the ribs and clavicles are equidistant. Okay. check if the chest is actually supine or upright, and you check for the exposure if the spine is seen through the heart. We also talk on the thymus, which starts to disintegrate by 2 to 8 years old. We also mention on the anterior and middle posterior mediastinal masses and its contents, no? We check on the normal and abnormal position of the trachea, different signs of headache, pneumothorax, mediastinum, and the different entities causing increased lucency or darkness of the lung, and different entities causing opacity of the lung. Oh, practice image muna tayo. Okay, these are 3 images, no? With almost the same findings. There's opacity of the left lung. However, there are clues that would point to a certain disease entity, no? Try to think of the diagnosis for 5 seconds, then we'll tackle this one by one. Okay. First image is actually pneumonia, no? You can see that the opacity is here. You can see that there are branching lucencies, no? Air bronchogram, and you can see that the midline structures in trachea are not pushed, no, or are not pulled towards the area of abnormality. So wala siyang volume loss. This is a concentrated pneumonia. So this image, this is a massive atelectasis. You can see that the midline structures, trachea is deviated to the left side, the midline structures in the heart is deviated to the problem side. There is compensatory hyperration of the opposite side. Finally, is a massive pleural effusion. You can see that the midline structures are pushed, no? The trachea is pushed to the contralateral side by these three factors. Doctor? Hello? Dr. Montes?
Yes, Doc.
Do we still have time o okay na tayo?
Yes, sir. We still have time, sir. Go ahead.
Ilang minutes pa tayo, Doctor?
Okay lang, Doc.
Okay lang, okay. I'm sorry kanina, my train of thought was daming nagpa-follow up ng trace of thought na daming tumutunog ng mga Viber, pa-follow up. Sorry, nawala yung sorry. Okay, so let me just discuss on most common causes of respiratory distress in newborns. Now for this, for RD, we have 3 factors. We have the upper airway, cause respiratory distress in newborns, blocking. We have the lung parenchyma, and we have development. We have extrapulmonary causes as well. No, these are pulmonary causes. Extrapulmonary causes would trauma, cardiac failure, folic acidosis, asthma, intercostal muscle paralysis. Now for the diseases of the airway, we have from the nasal part, pulmonal atresia, nasal atresia, oral cavity, we have macroglossia or macrognathia. We also have laryngeal obstruction, such as laryngeal web, stenosis, laryngeal malacia, and paralysis. And we also have a mass, such as hygroma or congenital goiter, which causes obstruction in the neck. We also have tracheal obstruction, such as tracheal malacia or tracheal fistula or tracheal stenosis. We also have developmental defects, diseases of the lung, hypoplasia of the lung, diaphragmatic hernia again, cardiac fistula, agenesis, June syndrome or thoracic dystrophy. However, let me just concentrate for this lecture lang on the entities cause respiratory distress in newborns that arise from the lung parenchyma itself. More common ones are aspiration pneumonia, aspiration syndrome, respiratory distress syndrome or SND, transient pneumonia of the newborn or wet lung disease, or infection or pneumonia, whether viral or bacterial. We will also discuss a little bit on fusion, air leak, or mass. Actually, we discussed this a little bit earlier. First, we have a full-term newborn, addicted to the need to labored breathing. Diagnosis of meconium aspiration is suspected when a neonate shows respiratory distress in the setting of meconium-contained amniotic fluid. So the patient is just delivered with meconium-stained amniotic, tapos may labored breathing, consider tayo ng meconium aspiration syndrome. Especially, it appears like this. Meconium aspiration, bilateral patchy portion interface are seen. Okay. Lungs are hyperrated with variable passive pulmonary hepatitis due to subsegmental atelectasis or consolidation. No? Subsegmental atelectasis are due to bronchial obstruction, the exudates, or consolidation due to chemical pneumonitis. Partial blockage actually leads to air trapping on inspiration, resulting in a hyper-expanded lung. No? And you should also check for possible pulmonary air leaks. Look for pneumothorax or pneumonia, especially in patients who are hyperrated. No? So patient full-term male, respiratory distress, requiring ventilator, and showing patchy pulmonary hepatitis, no? With associated atelectasis and marked hyperaeration. In the setting of tickling meconic amniotic fluid, consider meconic aspiration, which are presented with this image. Next, we go to respiratory distress syndrome, or highly negligent disease, or surfactant deficiency disease. Disease is due to insufficient production of surfactants that occurs in preterm neonates. Okay, that's a term, no? That's a term for preterm neonates. Respiratory distress presents in the first few hours of life in a premature baby. It is due to the lack of surfactant that increases the surface tension in the alveoli, causing the collapse or the microartery. For your radiographic pictures, you should always see low lung volumes. These are mandatory. Low lung volumes. If you see hyperinflation, hyperaeration, other than if the patient is intubated, think of other disease entities na lang. Okay? This is mandatory, low lung volumes. Also, you see diffuse granular hepatitis, which are bilateral and symmetrical. You should also see air bronchograms, and the thorax is actually bell-shaped. Okay, example of images, no? Symmetric groundless hepatitis, low lung volumes, hindi siya hyperrated. And also check for pleural effusion. No? There should be no pleural effusion. Usually there is no. Usually wala siyang pleural effusion, especially in early stages. And air bronchograms as well. Same disease, no? Mas lesser lang ang kanilang opacity. Okay. Next, we go to the wet lung disease, or transient tachypnea pneumoniae, which presents in neonates as tachypnea on the first hours of life, lasting up to 1 day. Most commonly seen in patients born through cesarean deliveries. It is seen in term or near term. Term or near term neonates. This is hypothesized to be due to reduced mechanical squeeze and reduced capillary and lymphatic removal of amniotic fluid in the lungs, which should be normally expressed from the lungs during vaginal delivery. For the radiographic findings of wet lung disease include interstitial edema, which is predominantly perihilar, often seen as perihilar stickiness. We also see hyperaeration, and we should also see resolution by 48 to 72 hours postpartum. Sometimes, because it's wet lung, because it's wet, you can also see sometimes minimal pleural effusion, as well as thickening of the minor fissure. So these are clues that could help you diagnose this patient. Ayan. Symmetric perihilar infiltrates, again, thickening of the minor fissure. Okay. In the patient presenting with tachypnea, born by C-section, mag-isip ka na ng present tachypnea ng newborn. And then do follow-up study, no? After 48 hours, this is what happens, no? This is your second day X-ray. This is your X-ray after 48 hours. You actually see marked reduction, no, of the interstitial thickening in both. No? So, tama ang diagnosis mo of transient tachypnea of the newborn. Okay, for pneumonia, it could be diffuse alveolar or in the interstitial type. It's usually asymmetric and localized. Most frequent alveolar pattern is the dense bilateral airspace infiltrates with air bronchograms, no? As we have already tackled earlier. Sometimes, but in pneumonia, some normal X-ray will also be seen, no? Just like in asthma. Effusions or empyema may occur with any bacterial pneumonia. Group B-step pneumonia may resemble that of the RDS, no? The findings of respiratory distress, mga branching granular patterns, no? With air bronchogram, diffusely involving bronchograms. Hematocysts can also occur with staph pneumonia. Okay, neonates, check for history of premature rupture of membranes or prolonged or complicated report of patients with neonatal pneumonia. So for early onset pneumonia, it occurs in the first week of life. Early onset occurs in the first week of life as an intrauterine pneumonia, often caused by group B strep or gram-negative bacteria. Late onset occurs in subsequent 3 weeks, often caused by gram-positive bacteria. example of neonatal pneumonia. As I mentioned earlier, parang RDS din siya, no? Use ground glass cavities with pneumogram. Pero this one is more of pneumonia because it's asymmetric. No? We have hyperinflation as well with pleural effusion. Okay, with pleural effusion. Okay, clues in the diagnosis. So how do you differentiate the different entities? No? Kasi if you can see naman for the untrained eye, parang pare-pareho lang sila yung images, no? If you see coarse reticular findings, no? Coarse reticular infiltrates, ano ba, it is pneumonia, it is congestion, it is RDS, but your clinical clue is thick deconing staining at first, no? In patient with fetal distress. For the X-ray clue, you look for effusion. Diffusion is more common in pneumonia. So kung wala siyang fusion, you can lean towards recording aspiration rather than bacterial pneumonia. Pwede ka mag-isip ng RDS. Now, check for if the patient is full term. If this is a case of a full term patient, then you can cancel RDS. So in patients which are normal vaginal delivery, you can actually, it's rare to have PTN or wet lung disease in patients with normal vaginal delivery. So in patients with coarse reticular capacities, in a setting of a thickly recording fluid and the patient with fetal distress, you can consider recording aspiration pneumonia. Again, premature newborn because of distress. Same pattern. Yan, ground glass opacities, usually involving both lung, with a pneumogram, low lung volumes. This one has pleural effusion as pointed by the arrow. This one has none. No? But what do you consider? Premature respiratory distress. Isip ka ng RDS or pneumonia, di ba? Yan naman ang usual. So, your clinical clue is gestational age, premature. So, isip ka ng RDS talaga, especially if pleural effusions are absent and there are low lung volumes. Pleural effusions are rare in RDS. So, nakita ka ng effusion, if you see a band here on the lateral aspect of the thorax, mas you could lean towards more on group B stress infection rather than RDS. Okay? But your clincher here is the premature patient. Okay. Five reticular pattern in patient with C-section. As I mentioned earlier, reticular pattern is asymmetric, very higher and symmetric. You can also see fluid in the minor fissure and sometimes see diffusion. Isip ka ng wet lung disease or transient reticular pneumonia, especially in patients born by a C-section. Is this also could this be cardiomegaly as well? Pwede rin, kasi medyo malaki ang heart on eyeball, malaki heart, I can measure. Tapos may parang the vascular hilar markings are actually accentuated. You can actually think of congestion. So pwede rin. However, in congestion, the edema usually mas malaki. The heart is actually bigger than this, no? Tapos, if you do repeat X-rays, serial X-rays after 72 hours, and there's no clinical or radiographic improvement, now you can consider pneumonia. But initially, you can also think of PTN in patients who are born by a specific vaginal by a cesarean section, presenting with tachypnea. Okay. Okay. Finally, this is my last slide. In the interpretation of abnormal radiologic signs, although some X-rays are pathognomonic for specific conditions, in most cases, the diagnostic process still depends upon correlating the findings with the age of the child, the clinical history and examination, and if you have previous X-rays and other imaging modalities such as ultrasound or CT scan and lab reports, which could help in the overall picture of your diagnosis. With that, I end my